Now, we are nearing the end of our conference, but we can't end without hearing from our keynote speaker. It's my privilege to introduce Rani Morrison, the Chief Diversity and Community Health Equity Officer at the University of Illinois Hospital and Health Sciences System. I don't want to take up too much time, but I do want to give her a brief background about Ms. Morrison. She holds a BS in Sociology from Southern University and A&M College, a Master's in Public Service Management from DePaul University, a Master's of Social Work from University of Southern California, and is a licensed social worker. She's also a fellow in the American College of Healthcare Executives, a board member of the Chicago Health Executives Forum, a member of the Society for Social Work Leadership in Healthcare, and a steering committee member of the Women in Healthcare Chicago chapter. In addition to her extensive professional endeavors, Ms. Morrison is very active in her community, serving on several boards and leadership positions. So with that, I'd like to turn it over to Rani Morrison. During her talk, if you have any questions, put them in the chat and we will have time for a couple at the end.
Good morning and thank you for the introduction. I'm going to share my screen, so bear with me. There's a running joke. How many master's degrees does it take to share presentation style? So it's not my strength. So give me 1 second. To swap. Does everybody see just the one slide?
It looks perfect.
Awesome, thank you. So good morning, everyone, and thank you for having me. First and foremost, the panel discussion was fantastic. And the abstract presentations I just attended, all of them, I went into 3 different rooms. They were absolutely great. You all have done a great job putting this conference together, and I am so honored to have been asked to speak. Bear with me as I'm used to speaking in person. I am a pretty social person, so I'll admit you have to know yourself. I'm someone who kind of gives and takes from the audience. So those of you who are on camera, I'll be looking at you a little bit to let me know if I'm hitting the right note. I'm approaching this kind of as a casual conversation because it's been a long morning, and I know we've done, you've heard a lot of talking, and I don't want to just give you information, but I want us to have a conversation as I've thought about what we needed to discuss today and what the theme of today was. So I just want us to walk through kind of some stories because health equity or health inequity is not a new concept. I think in the last few years, we put a name on it of late, but it's not a new concept. It's been around for a long time. I mean, as long as, you know, society has been in existence, health inequity has been in existence as well. So I just want us to kind of walk through the past so that we can continue to think critically about how to improve the future. For context, and you heard my introduction, so I won't regurgitate anything there, but just so you know, I've been at UI Health since 2014. My current role is Chief Diversity and Community Health Equity Officer. This is a new role for the health system, and I'm excited for this opportunity and the initiatives that are underway to further develop our own health equity programming. Health equity has been in our mission for a very long time as the hospital and clinics. So this isn't new for us either, but formalizing our health equity programming under one office for the hospital and clinics is a new initiative, as well as formally implementing diversity, equity, inclusion, and belonging strategies for the hospital and clinics is a new initiative as well. Prior to this role, I did different things here, such as Senior Director of Care Continuum, so working with our social work, case management, care coordination, financial case management, discharge planning areas. I was the Director of Care Coordination. I've worked in HIV and AIDS, research, nonprofit. I've worked in Medicaid health plans. And I tell you all of that because I want you to have a little understanding about the lens through which I view health equity. I started my career a little over 20 years ago in Louisiana. In Baton Rouge, Louisiana. I worked in rural Louisiana as well in HIV and AIDS, and then I moved into pregnant and parenting teens and working in some very interesting areas of outside of Baton Rouge, such as Plaquemine, Louisiana, Port Allen, Louisiana, places you, if you're not from Louisiana, probably never heard of, probably will never go to. But cutting my teeth in healthcare in those areas where there was a lot of disparity, a huge difference from where I grew up outside of Atlanta, a huge difference in health literacy, in income, in education. And that's how I started my career, is working in those areas and really seeing what those disparities look like. So as I transitioned from Louisiana to here and came to Chicago 20 years ago, I worked in areas of Chicago where our income is higher than Louisiana. Chicago is one of the most educated cities compared to especially parts of Louisiana. We have, so many colleges and universities and institutions. Our average median income is higher. But many of the same issues that we experienced in Louisiana, we still experience in Chicago. And that's a similar story for many, cities and compared to rural areas and so on and so forth. So that being said, the prism through which I look at health equity, health inequity, health disparities has been, fortunately or unfortunately, very broad because I've been able to look at the way that we provide healthcare, the way that people receive healthcare and access healthcare in this country through a lot of different prisms. So that being said, I'll also add, as a point of personal privilege, I'm the mother of a chronically ill child who is now an adult. But my daughter has a number of illnesses, starting with her being hospitalized in the NICU when she was less than 12 hours old. And in the 20 years since, she's been in the hospital upwards of 25 times, probably been in every emergency department in this city, has had numerous surgeries, and has a number of chronic conditions that she's on medication for. All things considered, she's very healthy. I have no complaints, and she doesn't either. And she knows I share this story. She's in college and she does well, but I learned the healthcare system in addition to my professional endeavors. I learned the healthcare system because I spent a lot of time accessing it on behalf of my daughter. And so I learned where there's opportunities, challenges, inequities, biases, and all of those other items within the healthcare system as I've navigated it. It helped with my perspective and my lens as a healthcare leader as I've continued to grow and mature in the space. So I say all that to say I worked in health equity before we ever called it health equity, and that's the lens in which I come to you this morning. So as I thought about today's theme for the conference, one thing kind of kept coming back to me, and the saying goes, the more things change, the more they stay the same. When I was younger, that saying always confused me. Is that possible? If things change, they can't possibly be staying the same. But as I've continued to mature and experience the world, I've more clearly begun to understand what Jean-Baptiste Alphonse Karr meant by that. Even as things continue to change around us, most things remain constant. We need to understand what happened in the past in order to be able to continue moving forward. So when I was asked to address the conference today, I thought long and hard about this topic and the richness of the theme, impact of changing community structure on health equity. I think for me, as I've thought about impact of changing community structure, I think kind of a lightning rod change for people as we think about recent history has been the last 2 years. And so I thought about a lot of different approaches to this theme, but what I kept coming back to was this. We've looked at, my role, Chief Diversity and Community Health Equity Officer. That's a new role at a lot of different hospitals and health systems, Chief Diversity Officer, Chief Health Equity Officer. A lot of different health or care organizations are moving forward with that. You see a lot of roles and programs funding now addressing health equity, addressing diversity and inclusion in healthcare. It's really what I like to call a hot topic of late in the last 2 years. But for me, many of you, my colleagues and peers, such as those who were on the panel earlier, Dean Giles, Dr. Pendleton, others, this is not a hot topic or the result of recent events or even a changing community. The conditions have existed for generations, and our careers and passions have been built around trying to address health equity and health disparities in various ways. But as much as communities, organizations, and even individuals change, we have to understand what happened in the past in order to continue to get our hands around it to address it in the future. So a good example of understanding the past would be, let's look at life expectancy. Although healthcare is one of the most turbulent and fast-changing areas in modern society, while our changes to technology, technique, and outcomes have moved at a relatively fast pace, our ability in healthcare to close the gap between races as it pertains to life expectancy has moved relatively slow in comparison. For example, studies have shown that Black American mortality is higher compared to whites for centuries. Racism is, of course, a primary factor, as well as other social determinants of health. While we know that conditions may change decade over decade, century over century, so water is better than it is, now than it was 100 years ago. But the fact that these conditions still exist in terms of this gap in life expectancy, that these conditions still exist, that social determinants are still having an impact on these conditions, means that persons of certain races, ethnicities, genders, sexual orientation, these changes and these gaps are not new. They've been in existence and they continue to persist. So we have to bear in mind as we continue to try and close the gap that it's a slow moving process, but that doesn't mean that we shouldn't continue to try. But we just have to recognize that we're continuing to address something that is pervasive and has been in place way before any of us got here. And so as you can see on this graph, you look at the life expectancy for all of us, at the beginning of the 1900s, and everyone's life expectancy has increased. But as you can see, the Black life expectancy is still the lowest amongst everyone. It's higher, but still low. I also included a headline from a few years ago that I'm sure many of you are familiar with. Chicago, out of all the cities, has the largest life expectancy gap in the entire country. According to a 2019 study by the NYU School of Medicine, those living in Streeterville, which is where Northwestern Memorial Hospital is, Lurie, the Gold Coast, Water Tower, compared to those living in Inglewood, Streeterville residents live to the age of 90, and those living in Inglewood live to the age of 60 on average. So within our own city, there's a 30-year difference in life expectancy, depending on where you live. That is significant that your zip code can determine how long you live. And again, we understand that it's not simply zip code. We also know that those zip codes have a significant difference in income and education and access to care and all of these social determinants of health that we know of. But those conditions are driven and attached to those zip codes. And so it does drive how long someone lives. And it's something that we have to, again, be constantly aware of, that this disparity exists so that we can continue to address it. Because even as we talk about changing communities and these changes that have happened and these, for a lot of people, it feels like there's a significant change that happened in the last 2 years, but these conditions have existed for a long time. This is not new. So that being said, over the last 2 years, mainstream media in particular, has posited that there's been a significant change, right, to our communities, to our society. Many healthcare institutions have positioned themselves as if this is new, as if we've just realized that healthcare is not equitable, as if we've just understood that racism is real and present, and that racism is a public health crisis. As if we just understand that people, our communities, our patients receive inferior care simply because of their race, ethnicity, or zip code. But in actuality, we know that this did not start 2 years ago with COVID-19 or the murder of George Floyd. These conditions have existed for a long time, for generations, for centuries, in the United States in particular. So as we talk about, again, that the theme of changing communities and health equity, what stuck with me was there were some significant events that have happened and impacted our lives, for absolutely sure, starting 2 years ago with this unprecedented pandemic, a lifetime event, right? But the conditions that we are experiencing that contributed to the way that the pandemic has impacted certain communities did not just begin to exist 2 years ago. I like to say that it exacerbated the conditions that were already in existence. And we'll talk a little bit more about that in a few minutes. But what I wanted to do was talk a little bit about, again, the more things change, the more they stay the same. I wanted to go back a little bit as we think about kind of the history of some of the things that have happened in the past and examples of health inequities and how we've handled them. Again, not to unsettle us, but I think it's always good to understand where you came from so you can chart out where you're going. And so one of the abstracts that was presented spoke about vaccine hesitancy in certain communities. And I was in that breakout session. And so that aligns with something that I know in talking to people in the community and hearing a lot of things and seeing things on social media when the vaccine rolled out. The Tuskegee experiment, as people call it, was one thing that got a lot of traction when the vaccine was being rolled out, especially amongst the Black community. And I'm sure, I know for the students and any student, you're familiar with it because we all had to do that lovely CTI training at some point in our education where we were trained to on the human protection module. So I know you're familiar, but let's just talk a little bit about Tuskegee and what it meant, because it's a significant event. And it plays a part into health equity and the perception of healthcare, perception of government, and in particular communities. So it was officially called the Tuskegee Study of Untreated Syphilis in the Negro Male. In 1932, the United States Public Health Service began working with Tuskegee Institute, which is now Tuskegee University in Alabama. It's a historically Black college and university, to study the trajectory of syphilis in Black men. They followed 600 Black men, 399 of them with syphilis and 201 without it. The participants were told that they had bad blood and received exams, meals, and burial insurance as part of being in this study. At the time, there was no preferred treatment for syphilis. But about 11 years later, in 1943, penicillin was identified as the treatment of choice and was widely available. However, the participants were not offered this treatment or made aware of its existence at that time. Instead, they remained enrolled in the study as is. The study subsequently continued until 1972. The study was then stopped, and there was an investigation into the ethical failings of this study. Subsequent to that, new regulations were established to protect human research subjects. There was an out-of-court settlement that occurred in 1974. A program for medical care for their survivors and their families was established in 1975. A point that sometimes has to be clarified was that the government did not, for example, inject the participants with syphilis. They didn't give them syphilis. They just simply didn't alert them that there was a treatment for syphilis and didn't offer it to them when it became available. So they withheld information from them as, even though they were enrolled in this study. The families were enrolled in this medical care program. And as a result, there was even a presidential apology that was issued in 1997 by President Clinton. One of the long-lasting effects of the Tuskegee experiment, as it's commonly called, has been, in addition to the fact that we got human research subject protection as a result of this study. So now, again, for those of you students and doctors, you know all of the things we have to go through, IRB approval, the trainings, and all of these sign-offs to make sure that the research subjects are protected when we initiate research. That's a benefit. A downside of the Tuskegee experiment was that there, as a result, there's a pervasive distrust of medical establishments in the Black community because of the history of this study. And this kind of kept rising up when you would talk to people throughout the COVID-19 vaccine deployment, particularly in the Black community. There were concerns that the government, that healthcare organizations, that there was deception in the messaging around the vaccine. And it was likened to Tuskegee, where there was information that was withheld. And it's hard to argue with something that was so horrific on record being part of this country's history, and challenge someone's interpretation or their understanding of it, even though it happened 50 years ago. That's not that long ago. And so it's an example of how health equity is impacted when there's certain things that have happened in the past. And even though we might have changed and society may have moved on, we have to understand what happened in the past in order to move forward in the future. Another example of significant health equity and the impact was the HIV and AIDS epidemic. Around 1981, for those of you who are familiar, reports of high rates of rare forms of pneumonia and cancer in young gay men started to spike. And then those infections started to spread to injection drug users. In 1982, the disease was formally named Acquired Immune Deficiency Syndrome, AIDS. And it is discovered it is transmitted by certain body fluids and sexual transmission. The disease is then found to be prevalent in gay men, and over the next few years, it is determined that the mode of transmission is semen, vaginal fluid, blood, and breast milk. The government response to this disease initially was slow, despite thousands having died from it in the first 3 years. It was first discovered in 1981, and it was September of 1985 before the sitting president said AIDS publicly. Those who were living with AIDS and human immunodeficiency virus, which was the predecessor to AIDS in terms of clinically, were segregated within healthcare facilities. They were denied care sometimes. Some hospitals had what were called AIDS wards. As a matter of policy, gay men were banned from donating blood. There were doctors who were ostracized, evicted from their clinics for treating persons with AIDS. There was a ban placed on visitors to this country and immigrants who had HIV that lasted for decades. The AIDS response, such that it was in the 80s, became about due to a grassroots effort led by the LGBTQ community that had been so devastated by the disease. And at the same time as the LGBTQ community was aligning in order to move forward with support and advocacy, the disease prevalence continued to rise amongst injection drug users and Black and Latinx, both men who have sex with men, as well as amongst females as well, in those racial categories and ethnicity categories. So now, 40 years later, and this is 40 years since the official naming of AIDS in 1982, as a country, we now understand it better. We have better treatment options since the development of antiretrovirals in the late 90s and the implementation of the Right Cares Act in 1990, which allowed so many to then receive care that they have been unable to receive for so many years. The Affordable Care Act in 2011 allowed many more people who had AIDS and HIV to receive care because they were able to qualify for insurance and Medicaid where they couldn't before. But there's really no better example of, again, health disparities and inequity than a disease such as HIV and AIDS that was prevalent in the LGBTQ community, prevalent amongst persons who injected drugs, prevalent amongst minorities, in particular Blacks and Hispanics, being stigmatized. The disease was under-resourced, and there was flat out open discrimination in the government and in healthcare organizations for years with the systems that were supposed to help and treat persons that were living with HIV and AIDS. This all happened in these first, in particular, the first 15 to 20 years of the AIDS epidemic, before we were able to make the adjustments that we needed to make overall as a country and a society to properly treat people who were living with these diseases and move to prevention at the same time. Now, persons who have AIDS are able to receive organs and transplant. We've also been able to allow them to donate organs, which was a limitation before. as you can see, I know you might see on the commercials now, there's different commercials for AIDS related drugs. We have PrEP therapy, which is now more widely available. So we've finally gotten to the point where we are treating HIV and AIDS differently than we were 15 years, 20 years ago, as we've moved along. But it was the epitome of a health disparity and health inequity for many years in terms of how we treated it. Even the institutions that were supposed to be assisting and caring for persons that were living with HIV and AIDS. Another disease that is kind of a great example, I hate to use the word great, it's not always the right adjective, but it's a great example of health inequity, is sickle cell disease. Sickle cell disease, if you're not familiar, is an inherited blood disorder where the blood cells become hard and sticky and look like a sickle. This causes a constant shortage of blood cells that can get stuck and clog the blood flow, which then causes pain, infection, and other issues for the patient, such as strokes. This disease is more prevalent in Blacks and can also occur in Latinx populations as well. There are approximately 100,000 Americans who have it. According to the CDC, the average life expectancy for persons with sickle cell disease is 43 and 41 for males. As you can see, this is a deadly disease that disproportionately affects persons of color. However, despite this being a well-documented disease of pain, a disease with a high mortality rate, persons living with sickle cell disease report routinely receiving poor treatment in healthcare organizations. They're often labeled as drug seekers. Pain is subjective, and clinicians who aren't familiar with the disease make assumptions. Bias can also play a significant role. But imagine being so sick with a disease that you're in pain every day, you go to the emergency room for help, and then you're treated poorly on top of feeling poorly. To exacerbate the inequity, sickle cell disease has historically had inferior research funding as compared to other diseases. I won't get into the specific funding numbers for comparison, but as you can see, sickle cell disease is more than 3 times as common as other genetic disorders in the United States. So you would think that the funding for research would align appropriately with those numbers, and it doesn't. But again, this is a disease that disproportionately affects persons of color, has 100,000 people in America that are currently living with it, and a shockingly short life expectancy. Health equity would be ensuring that there is equitable research funding for cause, treatment, and cure around sickle cell anemia. We have to understand what has happened in the past in order to be able to work forward. A more recent example of when we don't understand, when we're continuing to not understand all the motivations and things that go into how we get where we are. The Flint water crisis is a much more recent example, not something that happened 40 years ago or 50 years ago or has been a permanent state, but just 2014 was the start of the Flint water crisis. The emergency city manager of Flint, Michigan, made a decision, an economical decision, to route the city's water supply from the Flint River rather than piping in the treated water from Detroit as they had been doing. They did not treat the water, and therefore the residents were drinking river water that was led through corroded pipes. Despite numerous complaints from the residents that occurred right away, it took years for the Environmental Protection Agency and the state of Michigan to intervene, investigate, and supply bottled water to the residents. In the meantime, the children of Flint drank water with lead in it for a minimum of 18 months. That's a minimum. At the same time, there was also a concurrent outbreak of Legionnaire's disease that killed 12 people. All in all, in Flint, Michigan, there were up to 12,000 children exposed to lead orally through the water, 79 lawsuits, 15 people indicted, and 1 person convicted as it relates to this epic failure. This was an epic failure from the government, Environmental Protection Agency, public health. This is health inequity, as illustrative as you can get. This was done to save money on top of that. In a city that, if you look at the statistics, is decidedly working class, majority Black, has a low percentage of college-educated residents. And one thing to note is you have Auburn Hills, Michigan, which is a few miles down the road, was the former home of the Pistons, and has a much higher tax base and average median income. And you have to wonder, would this have happened and been allowed to go on as long as it did for 5 years if it had been in a different demographic? With this health inequity, with this disparity, this risk to the children of Flint have been allowed to go on. We're still getting information in about what the impact to the children are. Parents are still reporting significant changes to their children, mental changes and other physical changes that have occurred with these children. But it might be years before we have a full understanding of what the impact to the children of Flint was actually based on this. One thing that came to mind when I was thinking about understanding the past as it relates to understanding the future is when I was an undergrad, the Journal of American Medical Association released a study that looked at maternal mortality over the previous decade. And the findings indicate that in every state where maternal mortality rates could be reliably calculated, Black women were more likely than white women to die from complications of pregnancy. I actually used the statistic in a paper I wrote back then. Today on the CDC website, Black women are 3 times more likely to die from a pregnancy-related cause than white women. So continuing to understand where we came from, again, the more things change, the more things stay the same. We have to understand what has happened in order to be able to critically think about what we need to do to fix it. Because things are moving, but they're not moving at the pace we need them to move because we're not really taking into account what happened. Dr. Shanice Wallace, pictured here, was a pediatric resident in Indiana that died shortly after giving birth to her first child in October 2020. The maternal mortality rate for Black women and Hispanic women is a growing area as well. They both remain abysmal in comparison to white women, even when income, education, insurance, all of that is controlled for. So while health disparities and inequities did not just begin and are longstanding, the recent awakening, as we talked about, has caused the healthcare community writ large to reprioritize, to recognize that racism is a public health crisis, to recognize that health equity is not just about offering the services or having the best care available. If you build it, they will come, with a saying. It's not necessarily the truth. We can offer the best, highest quality care, but if our patients can't access it, if they don't know it's there, if they can't afford it, if they can't travel to it, if there are any other barriers in the way, then we are not providing equitable care. This is a good graphic, and I know you've probably seen this in different venues. Equality means, yep, everybody has the same thing. It's all there. But equity is adjusting the playing field so that everybody can access it. And for us to achieve health equity, we have to be able to start addressing these barriers in a more tangible way for our communities, our patients, and those that we're trying to serve. So what did COVID-19 do for us that changed the landscape a little bit? The one thing I will say about the changing communities and looking at the past compared to now is that everything was exacerbated by COVID-19 in particular. These are social determinants of health that were always in existence. These aren't specific to COVID-19. These aren't specific to police brutality. These were always in existence. But COVID-19 kind of leveled everything up, right? So transportation. Patients couldn't get to their appointments. They couldn't get to testing. They couldn't, when public transportation shut down, people couldn't get to where they needed to go, the grocery store. They couldn't access things. If you couldn't afford Instacart, then you couldn't get groceries, right? Health literacy. Sometimes we had patients who didn't have an understanding of the risk and prevention strategies around COVID-19. They didn't understand maybe when to return to care after they left the emergency department. They didn't understand how to take their pulse ox. They didn't understand issues around stigma and when to tell someone or how to isolate and those types of things. Employment and socioeconomic status. We found out that our gig economy, our servers, our hairstylists, our daycare workers, there was a lot of precariousness in that gig economy. And so it really impacted people when they did not have a job to go to every day and it shut them down. It really made it a precarious situation for a lot of people. That was again, employment and socioeconomic status has always been a social determinant of health, but when you go from something to absolutely nothing, that's a significant impact on your health. Multi-generational households, infection was occurring in people's homes, and we were telling people, you need to isolate, you need to use your own bathroom. But if you've got 3 generations in a home and you've only got 1 bathroom, how can you isolate from your 70-year-old grandmother? Where do you go? Where can you go in order to keep yourself from infecting everyone else? You can't. So what we found were people were, the whole house was getting infected, and sometimes people were getting very sick and dying because you had these multi-generational households that just couldn't isolate from one another. There were not enough bathrooms. There were not enough bedrooms. Internet access, something that nobody necessarily thought a lot about, but when we switched to remote work, remote school, it became a very important thing that we realized everyone just didn't have access to. Access for seniors. We took for granted when we deployed vaccines that our seniors would hop on the internet and register for vaccines. But I'm sure you, like all of us, spend a lot of time trying to help seniors get on the phone and register for vaccines because they couldn't hop on quickly enough to register on the various websites. That was something that was exacerbated. We didn't think about it necessarily as a social determinant of health, but it very easily became one. Housing. People were holding onto their housing by a thread. We got the eviction moratorium, and then there was a bubble that burst when the moratorium was over. Race and racism, always there. But there was the racial awakening in the midst of COVID-19 and after the murder of George Floyd, and then a rise in racist rhetoric, in particular, the rise in Asian hate, tied to different things and that were said about persons who were Asian in particular. A lot of racism, racial epithets that were said, and people were unapologetic about it, just bold and out there. And finally, trauma and violence, always been a social determinant of health. Increase in violence after the first year of COVID. We had spent a year in isolation. And then after this first year, people were out. People, in some cases, were desperate. We had a lot of unaddressed mental health issues around our isolation and things that had not been dealt with. And people were grappling with economic challenges and isolation, and it increased trauma and violence as soon as that first year wrapped up. These are all social determinants of health that were present prior to COVID-19, but were exacerbated. So quickly, and I'll wrap it up because I know we're almost at the end of time, where to go from here as we think about health equity in our changing communities. The needle is constantly moving. Again, the more things change, the more they stay the same. Addressing health equity is a multi-pronged approach. We need our organizations, our government, our healthcare institutions, communities, clinicians, and our patients to all contribute. What can we specifically do to address the barriers, like examples on the previous page, to achieve equity? A holistic approach. Who is in front of you? What is the issue at hand? Do we know the community, or are we coming in with assumptions thinking that we're going to fix it? Have we done a thorough assessment, or are we making assumptions? Because if you're making assumptions, you're not going to be able to fix anything because you haven't addressed the actual community and the need. We need to invest in resources for the community and individual patients. Coming into any situation with no money and no action, you might as well not even go. There's nothing that you can do. We have to invest resources. We have to put boots on the ground. Otherwise, we're not doing anything. We're not making any inroads at all. And finally, we need to collaborate with each other, organizations, individuals, people, the whole nine, but we need to hold each other accountable. And that's, again, organizations, healthcare institutions, individuals, politicians. We need to hold them accountable to what they say they're going to do, all of us. If they say we're going to build something, make sure that they build it. If they say they're going to vote for something, make sure they vote for it. If they say they're going to fund something, make sure they fund it. If we don't hold each other accountable as constituents, as patients, as employees, whatever your role in life may be, if we don't hold the people that are supposed to be making changes accountable, then we're going to continue to be stuck and making those baby steps, and that gap in life expectancy will continue right where it is and not move. That maternal mortality rate will not move. Those conditions that have continued to exist for generations will continue to exist, and our children and our children's children will continue to suffer from them. I thank you for your time. I think I've used it all up, and I appreciate the opportunity.
Thank you so much. That was very enlightening, and I'm sure everybody else enjoyed it as well. Okay, so I will just go ahead and wrap up today. I want to thank all of you guys for attending the conference today. A special thank you to our advisors and the School of Public Health for their support. Of course, thank you to all of our panelists and Rani Morrison for speaking today. I think, getting all these professional and backed by experience insights was just fantastic. I also want to thank the faculty that are listed on the right here that helped with the abstract review process. And lastly, thank you and congratulations to all our abstract presenters. We hope you all had a great time this morning. Please fill out the feedback form that's in the chat and help us continue to improve this conference. And with that, thank you one last time, and we hope that you have a great weekend.